Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Well, as promised in my previous video, CPT E&M time, I have a tool, what I call a pacifier, to bring all of our knowledge of CPT E&M up to this point to a final code. So, if you have not viewed my previous videos on CPT E&M, up to this point, to where we're going to do the final E&M code, go back and view them before trying to use this tool, because you will need that knowledge in order to use this tool. This tool was created by Patrice Morin-Spatz, who taught CPT coding in the early 2000s. She no longer teaches, but I happen to have kept my tool because it helped me to understand CPT coding after I struggled with it. To me, the greatest problem that a coder faces with coding is to accurately code the evaluation and management section of CPT. The reason it's difficult is because it requires judgment on the part of the coder or the physician, whomever is doing the coding. They're going to have to put a little bit of their own personal judgment into it. It is of critical importance to note that not all of your encounters that you're going to face in your physician's office or whatever setting you're coding in will fit neatly into a prepackaged description that's listed in your CPT code book. You won't always have, for example, a problem-focused history, a problem-focused exam, and straightforward medical decision-making as described in Code 99201. This tool that I'm going to introduce to you today, called the doc form, which stands for Doctor's Office Checklist, will help you do just that. So let me show you the doc form. Okay guys, this is the doc form. Now I want to show you a little bit at a time. As you can see, this doc form, from left to right, you can see that both at the top up here, I have outpatient, office outpatient, and consultation. Okay? And right up under there, I have, okay, you see where I have new. I'm trying to show you a little bit at a time. New, and it has the number 3 in parentheses, established with the number 2 right up under office and outpatient. Because what you will learn is that a new patient must have 3 out of 3 components. An established patient must have 2 out of the 3 components. With consultation, your office or outpatient, you have to have 3 out of 3 components. Inpatient must have 3 out of 3. Going down the form from left, on the left here, notice I have your components: your history, your exam, and your medical decision making. And notice under each history, I have the 4 levels of history: problem focused, expanded problem focused, detailed, and comprehensive. Same thing for examination: problem focused, expanded problem focused, detailed, and comprehensive. And then medical decision making: straightforward, low complexity, moderate complexity, and high complexity. Another thing that I have down here is time. Remember in my last video I discussed the role that time plays in E&M coding? And right beside time there's a line for you to place the amount of time that your physician spends with the patient. Now that can be a habit that you can start teaching your physician to do, or if time becomes a factor in your E&M code and you need to monitor or track it, you can write it right there, or just have your physician check off 10, 15, 20, 25, 30, etc. as for time. Okay? Now, what I also want to show you is underneath, right beside your history, because this is the outpatient, office outpatient setting, and it splits up the new from the established patient, Notice it gives you the codes. For a new patient, the history, the code is 99201, right? For an established patient with a problem-focused history, the code is 99212. And guys, this came straight from my CPT, for example, 217. If I go to the E&M section, Evaluation and Management, Office, or other outpatient settings, when I go down to my first code, for a new patient, the code number is 99201, 202, 203, 204, and 205. And for my established patients starts with, notice, 99211. Guys, remember, when a patient comes in, and if you get a chance, read over what this description says. Office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare practitioner. Usually the presenting problems are minimal. Typically 5 minutes are spent performing or supervising these services. I've had patients come back in, the doctors put them on some blood pressure medication, and all he wants us, the nurse, to do is monitor the patient every morning, 15 minutes after they take the blood pressure medicine. And so a lot of times I just use the 99211 because the physician's not involved, but it is an office visit. So that's when you can use that 99211 code. But we'll talk about that in a little more detail at a later date. But notice under your established patient, your first code is 99212. After that 99211, 213, 214, and 215. And guys, these are exactly what's on the doc form. Okay. What it did, it separated out your new from your established under the office and outpatient. It listed your key components: history, examination, medical decision making, and then it put the codes there. So as we read examples of what occurred, we just circle what level of history, what level of exam, and what level of medical decision making. Okay? I'm going to try to expand on this and see if this will help you get a better view. It's getting blurrier as I get a little further out. All right, let's take an example. Let's suppose a new patient comes into your office. Let me give you let's suppose a 10-year-old new patient comes into your office complaining of itching on his leg. And in this case, your physician takes a problem-focused history and completes a problem-focused examination. Your physician decides that the patient has poison oak and that he needs a certain lotion. So it's straightforward medical decision making. The entire visit takes 10 minutes. So see how the number 10 is written on this line right beside it? So as you can see from this document, under the office, new patient, you need 3 out of 3. You have 201, 201, and 201. So because of this, and it's 10 minutes, and that's still 201, then this office visit would be coded at 99201. Okay? Because 99201 were circled 3 out of 3 times. And that lets you know, because it's a new patient, that must be met 3 out of 3 times. Okay? You ready to try another one? Okay. right, let's try another one. Let's suppose a new patient comes into your office with the same complaint, poison oak. This time your physician provides exactly the same services she provided with the first patient. Problem-focused history, problem-focused exam, with straightforward medical decision making. Okay, we see all that? Well, guess what? At the end of this visit, however, the mother of the little boy goes on to explain that her son has had problems concentrating in school and asks you for some advice on what to do. So in other words, this 10-minute visit now becomes a 30-minute visit. You see that? By looking at the circle on the doc form, you can see where time, 30 minutes, becomes a 99203. So for that reason, 99203 is the correct code for this second example, because what counseling or time, the amount of time the physician spent counseling this patient was greater than 50% of the total time. Notice that the code associated with the 30-minute time frame is 99203, 30 minutes. Okay? Let's take a final example. Suppose an established patient who seems very ill comes into the office. Your physician, now we're under established now, we're no longer under the new column, we're under established. Office visit. All right? He's very ill, comes into the office. Your physician performs an expanded problem-focused history, an expanded problem-focused exam, and because of the number of management options he has to consider, the amount and complexity of data he has to review, and the risk of complications associated with various treatments, your physician makes a treatment decision that is moderately complex. Okay? So we went with 99213, 99213, and 99214 because it was a higher level medical decision making, moderate complexity. Okay, so we see all that. So as you can see, this established patient must meet what? 2 out of the 3 key components, right? So as you can see, the circled codes, 99213 for the history, 99213 for the exam, and 99214 for the decision making. Because this is an established patient, 2 key components are required. You see that? Or either you have to exceed the key components or meet it. So in this case, 99213 would be the final code. Okay? Because 213, 213, 214, you only need to meet it 2 out of the 3 times or exceed it. There are many systems available. Okay? There are many systems available for choosing the appropriate E&M code. This is just one that helped me grasp this concept. On a final note, many people will tell you that it's better for you, if you can, to code a new patient visit because it pays more. But this is not necessarily true because of the 3 out of 3 rule for new patients and 2 out of 3 rule for established patients. So you may find that the exact service provided during a particular visit may render 2 very different levels of service. Let me show you an example of a new patient and an established patient with the same diagnoses. Let's say you saw a normal, healthy 24-year-old patient for her yearly physical. Okay? If she were a new patient and your decision making were straightforward, let me go to decision making. Okay, so notice our histories levels are the same. exams levels are the same, and medical decision making. Okay, here we go. We're straightforward. Even though you may have heard, or even though you may have done a head-to-toe check with the pap smear and obtained a comprehensive history, you would need to come to code this visit with a 99202 or 203. Because notice we had a 204/5, comprehensive, right? History, 99204/5, exam. But straightforward, it brought it back to a 201/202. So because you have to meet or exceed 3 out of 3 on a new patient, even though you're at a very high level history, very high level exam, and because you have a very low level medical decision making, it's going to bring this visit back. You can't stay with that high level history. It's going to bring this back to a 99201/202. The max you could probably get out of that is a 203 visit for that one. Okay? But yet look at the established patient. They had a 99215, 99215, and again, the easiest medical decision making, 212, but because you only have to meet 2 out of the 3, that visit would be a 99215. Okay? You can even create your own form depending on which setting you want to code in. For example, this form lists the codes from hospital, observation, and ER. And the only thing we do is you add, if it's the initial day in the hospital, you need 3 out of 3. If it's a subsequent day in the hospital, you need 2 out of 3. For observation, if it's the discharge date, it's a 3, or same day, it's 3. And then for ER, whether it's new or established, you need 3 out of 3 key components. Okay? All right, guys. Okay. So I hope this made E&M coding a little easier for you. Again, this is just one tool. There are some at the front of your code books, because remember I showed you in the front of your CPT books. Okay. That's the tool at the front of your E&M book. It's got some tools there. Okay. And this doc form is what I call a pacifier that helps you grasp the understanding of what is required to code an E&M. So again, and with the pacifier, you grasp the concept and it will start to make sense in your head. And then from there, you'll do away. You only need these forms. You'll see it in your head. You'll feel it. You'll know how to accurately code this. Okay? All right, guys. So I've put together a lesson plan that bring all of this information together, from new versus established, the key components, history, exam, and medical decision making, even to this doc form with practice exercises. So if you need a lesson plan on this or you want to practice with any of the CPT, email me at codemastercoach@gmail.com and request CPT E&M 1. Okay? All right, guys, that's it. I hope this made sense. Thanks, and I'll see you in the next one.